It's an absolute honor to bring back, I know for those of you who have been here, one of your favorite speakers. So, and actually, I have to bring this story up. So, most of you know Dr. Lewis, but we had an individual just come up to us while we were outside there, and it was a little bit of a funny discussion. She goes, I remember you. And he goes, yeah, I've been doing this for a few years and so forth. And so he goes, you're the blender guy. And if you remember his C. diff talk, and yes, he's back, but as most of you are aware, probably one of the leading experts in infectious disease pharmacy. A little bit different blender story. We're going to be talking about evidence-based approaches to the safe and effective management of invasive fungal infections. And to steal one of his terms, if your physicians and so forth say you don't have fungus in your hospital, you're not looking. And he is going to make that very clear to you today, I promise. So obviously I'm talking none other than Dr. Jim Lewis. He's the ID Clinical Pharmacy Coordinator at Oregon Health and Sciences University's Departments of Pharmacy and Infectious Diseases in Portland, Oregon. He received both his Bachelor of Science as well as his doctorate in pharmacy from Washington State University. He then went on to do his pharmacy practice residency at Southwestern Washington Medical Center in Vancouver, Washington, and then an ID specialty pharmacotherapy residency at the University of Texas Health Sciences Center and the South Texas Veterans Affairs Medical Center. Most of you are well aware of his accomplishments in the infectious disease literature. Without any further wait, I'm going to immediately allow Dr. Lewis to take over and entertain you for the next 45 minutes.
Yes, sir.
Go get him.
That's me. I'm Jim Lewis. There's the disclosures up there on the slide, and I'll let you take a quick look at those before we move on. Learning objectives. You are all crazy smart people. Otherwise, you would not have survived pharmacy school, okay? Therefore, I am not going to read objectives to you. These are the objectives for this presentation. We're going to talk a lot about fungal infections, and we're going to talk about the drugs that are used to kill said fungi. So, that is my major objectives. Here's the big wordy version of that. These are the 2016 IDSA Candida guidelines. If you work in an inpatient setting and you don't know where these are on your computer, on your phone, in your filing cabinet, I don't care where you have them, you need to get your hands on them. They're free, they are state-of-the-art, they totally agree with what the Europeans say. Everybody is happy now, okay? They're brand spanking new, totally updated. The last update prior to this was 2009. So really, if you are working out of this document for invasive fungal infections at this point in time, you're doing about as well as you possibly can be. And I cannot recommend this document strongly enough to you. When you think about invasive Candida, one of the real questions is, who is at risk? Who do you need to think about as far as development of these types of infections? And when you look at this list here, what you notice is, does that look like everyone in every one of your intensive care units? I mean, look at this. Central venous catheters. If you're in an intensive care unit and you don't have plastic coming out of every orifice, you're not an intensive care unit patient, right? We jam plastic into every orifice imaginable, and then when we run out of places to jam plastic, we call the surgeon so they can come create new openings for us to jam more plastic into, okay? So really, this is like how you create total opportunities for Candida to get in, because Candida looks at all that plastic as a superhighway into the patient, okay? It's all excited about that. You also want to look to see if they're colonized. You guys have any sick patients in your intensive care units at all? Anybody? Okay, I know in ours it's, you know, you pretty much have to be like 9½ toes in the grave to make it to ICU. So the severity of illness is no problem. I don't know about you guys, but in Oregon, as you're getting wheeled into our hospital, we're busy starting vancomycin on you. Right? So, I mean, pretty much everybody in your intensive care unit is on broad-spectrum antibiotics. This is the one that I think is really under-recognized. I would really strongly encourage you guys to really keep an eye on the invasive intra-abdominal surgeries that occur, especially the folks that have to go back for multiple washouts, okay? They go in, they take out part of their colon. They go in, they drain an abscess in the pancreas. Okay, those types of patients who then go on to develop leaks and have to go back for multiple washouts or develop recurrent abscesses seem to be at particularly high risk. And if you look, the IDSA in these guidelines really identifies that subgroup as being at particularly high risk. Guys, that is the group of patients, this group down here, that I really want you to have your radar super high on. Okay, you really need to be thinking about these folks. I'm not as worried about the guy who had an MI and is hanging out in your medical intensive care unit and, you know, maybe develops a little bit of a pneumonia. That's not somebody I'm going to get super worked up about. These intra-abdominal patients who've been on vancomycin for a week or vancomycin or vancomycin flagyl, and now all of a sudden their white count's going up and they've got intra-abdominal fluid collections, and hey, what's that white goo on their surgical incision? Right? Okay, those are the guys I want you thinking about. Necrotizing pancreatitis tends to be also a super high risk factor because a lot of times those folks end up on broad-spectrum antibiotics forever and a day because the surgeons really don't like to mess with pancreas patients. And then you can see these other things that we do to patients routinely are on this list as well. So as Randy already stole my thunder, okay? I hate it when the intro guy takes your dang lines, okay? Not cool. But if you're not seeing invasive fungal infections in your institution, you're not looking, okay? These are now the 4th most common bloodstream isolate in U.S. hospitals. 4th, okay? So if you're not seeing them, you're not looking. And that's really, I think, one of the things. If you're day 7 to 10 on an intra-abdominal catastrophe who was doing great on vancomycin, and now their white count's going up, their pressure requirements are going up, and they look like garbage, okay, time to be thinking Candida. Because you want to know what's resistant to vancomycin? Candida. Okay? And unfortunately, what happens way too often is that our providers run up and down the hall screaming that it must be resistant bacteria. Add tobramycin, add colistin, add Cipro, add bleach. Now, bleach will work, okay? Bleach will work for Candida. So, but really, I think one of the things you've got to be thinking about is invasive candidiasis. And the reason you need to be thinking about this is we know, very similar to bacterial infections, right? We know in the bacterial infection world, man, look at my coffee kick in. You see how bad that laser pointer's bouncing around? That tremor's terrible, okay? But really, if we know from bacterial infections that delays in effective therapy correlate with increasing mortality. Why, for a minute, would you think that's not true for invasive Candida? Okay, it is just as true for invasive candidiasis. And so if you're thinking that someone is at particularly high risk, they met all those risk factors we had on the previous slide, be thinking about starting that therapy earlier rather than later, because just like in the bacterial world, delays in effective therapy lead to increases in mortality. And when you're looking at specific Candida species, it's important to know what's going on in your hospital. If your lab is not identifying Candida to the species level in 2017, especially from blood cultures, your lab needs to be sued for malpractice, okay? Because there are a bazillion ways to do this now. It's not hard. It's very easy. But, okay, notice I did not say that every Candida from the urine needs to be identified and worked up. I said Candida from blood cultures for sure needs to be identified and worked up. Candida in the sputum, Candida in the urine, we can kind of talk about that as colonization goes. But Candida in the blood definitely needs to be identified. And the real problem that you've got here is the cockroach, okay? Candida glabrata is increasingly making up larger and larger percentages of bloodstream isolates in U.S. hospitals. And as you can see here, you've got susceptibility issues when it comes to Candida glabrata. One of the biggest mistakes I see pharmacists make when it comes to Candida glabrata is this statement: fluconazole-resistant Candida glabrata. Okay? I'm worried about fluconazole-resistant Candida glabrata. No, you're not. You know why you're not? Because it's not just a fluconazole problem, is it? Okay? The proper terminology here and the way to keep your docs from getting into trouble is to identify it as azole-resistant Candida glabrata. And that's really the issue. Candida glabrata doesn't care if you spent $2 on 800 milligrams of fluconazole or if you spent $500 on 300 milligrams of IV posaconazole. Its efflux pumps will spit it out exactly the same. Okay? So really what you need to remember is that this is an azole problem. It is not a fluconazole problem. And that's really where the echinocandins have developed quite a niche. Because as you can see, there's no cross-resistance between the azoles and the echinocandins. And according to the IDSA guidelines as well as the European guidelines, echinocandins are really now the preferred agents for invasive Candida glabrata infections because of that reliable susceptibility and in vitro activity. We talked a little bit already about the epidemiology issues, and these are long-running surveillance studies that have been done by the CDC looking at Atlanta and Baltimore and the population-level incidence of invasive fungal infections in those cities. And what you see is that in both of these cities, Candida albicans now represents roughly a third of bloodstream isolates. So you can see that, unfortunately, what has replaced that is Candida glabrata, with both cities experiencing rates of Candida glabrata approaching 1/3. Okay, so again, both cities look like this, and we've seen this in national surveillance data as well, that Candida glabrata now makes up roughly a third of bloodstream isolates in most U.S. institutions and cities. So this creates a bit of a problem for us because we know that a decent percentage of Candida glabrata isolates will have decreased azole susceptibilities. The other issue that we have is that blood cultures are notoriously insensitive for identifying Candida in the blood. We know that up to 50% of patients who have invasive candidiasis, their blood cultures remain negative. And so one of the things that we've really needed in the field is improved diagnostics. And this T2 magnetic resonance system, I think, is really kind of the next wave in Candida diagnostics. This is an opportunity to go straight from blood cultures into the machine and have an answer within a couple hours as to whether or not the patient has invasive Candida. The problem with this test is not that it doesn't work. Notice that the sensitivity and specificity are both above 90%. So this is a very good test. The problem with it is that it is $250 a test. Now, there is only one place that I'm aware of that hospital administrators like to spend money less than pharmacy, and that's lab. Okay? So when you go in and you tell your hospital administrators you're going to start dropping $250 a test on something that is the fourth most common bloodstream isolate in U.S. hospitals, you're talking about real cash money, and that is going to get your hospital administrators' attention. So I think one of the things that institutions that have used this device are finding is that they're trying to identify high-risk populations so that the testing is done on folks that can most benefit from it, where you're most likely to have a positive. And I think that's really going to be the next wave in antibiotic stewardship, is really helping our labs with test stewardship. Because one of the things that the lab struggles with is all of these new boxes and all of these new technologies, what do we bring in and what do we use? And I think this is a great example where technology maybe has gotten a little bit ahead of our stewardship and our ability to use it. So increasingly, though, these types of diagnostics will allow you to move from echinocandins to azoles or echinocandins to even no drug, right? So there's some drug savings that are potentially there, but also we need to make sure that we're using these more expensive tests, while they're great tests, in a very cost-effective manner. So when you look at this type of a case, you've got a 62-year-old woman with a history of diverticulitis. She's admitted with possible perforation of the bowel. She's been on Piptazo and Vanc. She has blood cultures drawn on hospital day 5 that are now positive for yeast. And again, this is one of the problems that I want you to think about. Remember that slide that I showed you early on, that effective therapy in less than 12 hours, mortality was roughly 10 to 15%? Is 5 days less than 12 hours? If you started therapy when this blood culture turned positive, you're already too late. This lady's mortality is 40% if you start effective therapy when this blood culture turns positive. And I think this highlights exactly one of the problems that we have with diagnostics and why T2 is potentially a major advantage. Now, I guess my question to you is, what do you think we should be doing with this patient at this point in time? I don't necessarily want you to answer out loud, but be thinking about what drug you would be going to and what dose you'd be using. The guidelines on a woman like this in 2017 would say that she should get Echinocandin therapy. And I think that's one of the biggest changes that we've seen from the 2009 guidelines, is that now the recommendation is that anyone with Candida in the blood receive at least a day or two of Echinocandin therapy while we figure out what's going on, while the organism is identified, and hopefully you're able to get azole susceptibility out of your lab. The alternative that would be reasonable in a patient such as this is Fluconazole. Fluconazole would be reasonable in that if she had not seen prior azole therapy and if she was not hemodynamically unstable. I also want you to notice out here the dosing of Fluconazole. I am still perplexed at the amount of underdosing of Fluconazole that I see in various institutions. Do not be the pharmacist who says they're being aggressive with Fluconazole while giving 200 milligrams a day to somebody with normal renal function, okay? We are not trying to annoy the Candida. We are trying to kill the Candida, okay? And so make sure that you're using appropriate doses of Fluconazole. The other thing that's very important to note here is that I'm saying Candida. Note the D in the middle. I'm not saying Canada. We are not trying to kill the country to the north. Okay? The Canadians become very twitchy about that when we talk about killing Canada, especially during hockey playoff season. They get very, very twitchy. Okay? So, but make sure when you're using Fluconazole that you're using adequate doses. Okay? Your starting dose in an ICU patient at minimum should be 400 milligrams daily. So, why do those recommendations look the way they do? You know, we want to know what is the best agent and where is the data to support the therapies that we're choosing. And this, I think, is really the best data set that we're going to get for some time. It's now going on 5 years old, and it was a review done by David Andes and his group that took basically 7 registration studies, 7 phase 3 randomized double-blind studies that had been done on anti-Candida agents over the last decade, and then went and did a patient-level drill down, so kind of an advanced meta-analysis, if you will, looking at all 3 classes of drugs and the outcomes and responses that were associated with them. They had data from almost 2,000 patients. That's unheard of in Candida studies. If we tried to do a prospective randomized study of invasive Candida infections and wanted to get 2,000 patients, that would take us forever. Okay, so this is really a very good data set. What is sobering to me is that the overall mortality remains in excess of 30%, because these are registration studies for the echinocandins. These are using our newest, best agents we have available to us, and we still have a mortality rate in excess of 30%, which I think says a couple of things. One, you have a lot of underlying comorbidities in people who develop Candida infections, but 2, this stuff remains very fatal even in 2017. The rate of treatment success was under 70%, which is still not satisfying when you think about how you'd want your family member to do if they had one of these infections. So, who did badly? Okay? If you wanted to know who was going to die, 1, don't get old. Okay? Getting old is always dangerous. Have you ever seen a study of a medical condition where old people did better? Okay? Not really. Getting old is a dangerous game. Also, don't be sick. If you have a very high 2 Apache 2 score, you are very likely to die. Also, don't let them suppress your immune system. God forbid you're old, sick, and have a suppressed immune system. You are in big, big trouble, right? The other thing, too, and I don't really understand this, but we've seen this data a couple of times, was that Candida tropicalis infections were associated with an increased risk of mortality. I don't understand that. Candida tropicalis is not inherently more virulent than any of the other Candida species, or at least it doesn't appear. And so I don't really know why that's there, but this is the 2nd or 3rd study where we've seen Candida tropicalis pop up as a predictor of mortality. So, this was what was likely to kill you in this study. What was likely to save your bacon? What predicted a good outcome was pulling the dang line, okay? If you remove the line, you cut the risk of death almost in half, okay? So, You're rounding in the intensive care unit. Your patient is critically ill. They have Candida in the blood. For some reason, the central line is not removed. I encourage the pharmacist line removal method. You accidentally trip as you're grabbing their central line and are leaving the room. Okay? Because line removal, did I mention, is associated with a 50% reduction in mortality. Guys, I told you earlier, plastic is the central line. It is the superhighway for fungus getting into your patient. Remove the superhighway. Close the superhighway. Candida gets in those lines and it slimes it. It biofilms it. It turns it into a bomb shelter. You can't get it out of its bomb shelter, so you have to remove the bomb shelter. Okay? So line removal was huge. Look what was number 2. Okay, treatment with an Echinocandin was associated with almost a 1/3 reduction in mortality. Okay, this is the data that led to the preferential recommendation for Echinocandins as frontline therapy for patients with invasive candidiasis over Fluconazole. Because remember, the comparators here were azoles and ampho. Okay, so Echinocandins appeared to do better. And it really didn't matter how you cut the data. You consistently saw this benefit of the use of the Echinocandin. And I think that this really, the assessment of lines, if they're not talking about the lines on rounds, bring it up. I know lines are not drugs. They're not what we stock in the pharmacy. But we are there to improve the care of patients. And line removal in this situation appears to be absolutely huge. The other issue that we talk about a lot is, what about somebody who doesn't have blood cultures? What about somebody who has all of those risk factors that we talked about? This is still an area that we really struggle with. And the guidelines basically say that in critically ill patients with risk factors for invasive candidiasis. All right, now listen though. This is the important piece. Notice the last part of this sentence, okay? And this is where we get into trouble. I am not telling you to walk through your ICU or skip through your ICU throwing Fluconazole on everybody in the unit. Okay, that's not what I'm telling you to do here. You need to make sure that there is no other known cause of fever before you start adding antifungal to these high-risk patients. Preference should be given to an Echinocandin. So they're basically telling you to treat them as though they're candidemic, even though you don't have a Candida blood culture, if they're hemodynamically unstable, they've had a prior azole, or you know that they've got a glabrata that's resistant to azoles. Okay? Those folks should be getting empiric Echinocandin. You can consider Fluconazole in folks who are less ill and have not received prior azole therapy. Here's where the stewardship piece comes in. Okay? You've got this high-risk patient. Their blood cultures are negative for Candida. You weren't able to find any other source of infection, so you started them on Echinocandin because they were hemodynamically unstable. Their blood cultures stay negative, and 48 hours later, their white count's better, their fever's better, their pressure requirements are down, they look great. They were colonized at the time with Candida in the urine, Candida in the sputum, and they had a ton of other risk factors. Okay? So what that says is the Echinocandin worked. That the Echinocandin treated a Candida infection that you were not able to identify. If that is what happens, you continue that Echinocandin for 2 weeks as though they were candidemic, but you just didn't find it. Okay? Now, this is where the stewardship piece gets tricky. How many of you think physicians have a hard time starting antimicrobials? Right? I mean, starting antimicrobials? Please. They do that in their sleep, right? Vancomycin, meropenem. Right? They have no problems starting the drugs. Are they good at stopping them? Right? My patient's getting better. Right? How many times have we heard that? Right? So the issue is, you can start the Echinocandin, or the azole, but you are supposed to stop therapy if there's no clinical response. This is going to land on us, guys. This is a stewardship piece right here, and this is the part where you're going to have to push. Because they're not going to argue with you much on starting therapy usually. But that stopping therapy at 72 hours, if there's no response and your cultures remain negative, that's where we're going to have to, I think, twist some arms a little bit. The other thing, too, is I am increasingly frustrated with the evidence in this area. We have a devil of a time proving that the strategy we're talking about, starting empirical antifungal therapy in high-risk patients, matters, that it works clinically. This is the latest, and this is a JAMA update on this topic. You can see JAMA clinical evidence synopsis. Basically, what they find here is that doing everything I'm telling you to think about doing, starting antifungal therapy in high-risk patients, even though blood cultures are negative, no decrease in mortality. There are fewer invasive fungal infections, but I am so not happy about this. Even if we do everything right, we don't seem to be decreasing mortality. So this is, again, an area where I think our diagnostics still need to improve considerably so that we're doing a better job of identifying patients at super high risk or who actually have the disease. What about susceptibility testing? Your lab can be and should be telling you in 2017 if your Candida isolates are resistant to Fluconazole. There are a variety of ways to do this. It is not hard. It is not expensive. So, and the guidelines are now recommending azole susceptibility testing for all bloodstream isolates. So guys, this is not the Journal of Pharmacy made it up. Okay? This is the freaking Infectious Disease Society of America telling you that you should be doing susceptibility testing on all Candida isolates from blood. Okay? This document is what you should be using to have this discussion with your lab if your lab is not already doing this. Echinocandin susceptibilities are much less common in most labs, and fortunately we don't see a lot of resistance yet. But if you have someone who's been treated with an echinocandin and now pops back up with another Candida species, you need to be thinking about this, because glabrata in particular seems to be okay at figuring out echinocandins after it's seen it for a little bit. So back to this patient case again. You've got this 62-year-old woman with a history of diverticulitis, possible perforation of the bowel, returns back to the OR for repair and leak of drainage of abscesses. She's been on micafungin for 6 days. She's now better clinically, but her blood cultures grew Candida albicans. Should she have received empiric therapy? You know, this, again, is the type of patient that I think you could make a very, very good argument should have received empiric therapy, but the data, as I just showed you from that JAMA evidence synopsis, is a mess. It doesn't show us the benefit there that I think we would really hope to see. This, though, is one of the reasons that I think we need to be very careful with the use of antifungals in general. I think we've kind of been lax. We've focused on antibacterial stewardship, but antifungal stewardship has maybe lagged a little bit behind because we felt, you know, maybe you don't see as much emergence of resistance in Candida. Maybe it's not as big of an issue. This is really kind of spooky. This is the emergence of Candida auris, which is a new pathogen that has been recognized over the past few years that has popped up on several continents. And the CDC issued a warning on it about a year ago now. And the issue with it is that it tends to be multi-resistant. Okay, so you're talking resistant to your azoles, resistant to your echinocandins, and resistant to ampho. The other thing, too, is that it's now been fairly well documented that you can have patient-to-patient spread, which is kind of unusual for Candida species. You don't typically see that. And then also, it appears that this may be selected by antifungal use, that institutions with high rates of antifungal use may get into trouble with this. I was reading the latest CDC updates on this yesterday on the plane here. It appears that this has actually been, at least of the U.S. isolates, most commonly found in your neck of the woods. New York, New Jersey appears to have some of the highest numbers seen on it. The CDC is recommending contact precautions for patients where this is identified at this point in time. And if you find this bug in your institution, it is supposed to go to your state health department to then be forwarded to the CDC. The other issue with this bug is that it's tricky for a lot of our lab systems to identify right now. So we need to kind of be thinking about that. If you see Candida hemolonii or Candida guillermondi, some of these other funky species, you might want to be thinking about this bug a little bit. There's very nice pages at the CDC's website that talks about this. Not super long. I would encourage you to familiarize yourself with what's going on here. All right, so to wrap up the Candida section, echinocandins for invasive Candida infections are the first-line drugs in 2017. Fluconazole remains a viable option for selected patients, and really I would argue that echinocandins and fluconazole are all you really need to know when it comes to drug therapy for invasive Candida in 2017. Those drugs are what you should be using to treat 98–99% of your invasive Candida infections. Line management is absolutely critical, in particular in the non-neutropenic host, where it appears that removal or proper management of central lines can be associated with up to a 50% decrease in mortality. The epidemiology we know has shifted over the last decade away from Candida albicans to more Candida glabrata, and we now kind of seem to be level with Candida glabrata holding at about 30% of bloodstream isolates. But you need to know what's going on in your institution. I can tell you what's going on nationally. I can tell you what's going on regionally. I can tell you what's going on at Oregon Health Sciences. But you need to know what's going on in your shop. Different units within the same hospital can even differ. You should be getting an antifungogram, basically an antibiogram, if you will, that deals with and tells you what species of Candida you're seeing and how often you're seeing them. That's not hard for your lab to do. It's just like putting together a bacterial antibiogram. The other thing that I think we need to watch is the emergence of echinocandin resistance in Candida glabrata, as well as the continued evolution of the Candida auris developments that the CDC has put out the warnings about. So make sure you're kind of keeping an eye on what's going on with the CDC's webpage there. With that, we're going to switch gears a little bit and spend the remainder of our time talking specifically about the management of invasive aspergillosis. These guidelines were updated as well last year. So you have brand spanking new Candida guidelines and you have brand spanking new Aspergillus guidelines. So both of these documents, if you take care especially of very immunocompromised patients where you see invasive aspergillosis, are very, very nice documents to have. The 2016 update from IDSA for the Aspergillus guidelines still has Voriconazole as the frontline therapy. And this is largely because the Isavuconazole data was not publicly released until right after the guidelines were pretty much done. The other thing that we see in these guidelines, very similar to the Candida recommendations, is to initiate therapy early. We've seen increasing data over the last decade that delays in infective therapy for invasive aspergillosis result in higher rates of mortality. The alternatives to Voriconazole in this document at this point are Isavuconazole, as well as lipid formulations of Amphotericin B. Most places, that's liposomal Amphotericin B that's being used, although there is still some Amphotericin B lipid complex out there. It's important to note that echinocandins are not recommended as primary therapy in this document, and that's because of the data that suggests that they're primarily fungistatic, and the outcomes data that have looked at echinocandins as monotherapy have not looked particularly good. So let's look at a patient case a little bit here. You got a 53-year-old male with AML. Normal cytogenetics, admitted for induction therapy, and they're planning to follow that up with a stem cell transplant. What fungal infections do you need to consider, and what drug classes are options in an individual like this? Well, first and foremost, you've got to be thinking about invasive aspergillosis in someone like this. And Voriconazole, as the guidelines have told you, remains the frontline therapy here. It is a very broad-spectrum agent, but it's important to note that it does not cover the mucorales. Mucormycosis is not covered by Voriconazole, and this has been an infection that has been seen as a breakthrough in patients who are taking Voriconazole for prophylaxis. The nice thing about Vori is that you've got both IV and oral formulations. The other very nice thing about the compound now is that it's generic, so you're getting a lot less pushback from insurance companies on it. As a matter of fact, this is the broad-spectrum azole they really want you using because it's considerably cheaper than either ISA or POSA. Also, you have pretty darn good oral bioavailability at roughly 80%, so you really don't need to be using the IV unless you're having major problems with someone's gut. However, there are significant limitations to Voriconazole. There are increasing concerns, and this data is emerging more in the dermatology literature, unfortunately. I don't know about you guys. I read ID literature quite a bit, but I don't read me much dermatology literature. And so with articles hiding in the derm literature, I miss them. And so a lot of this is becoming increasingly recognized by the dermatologists that long-term use of voriconazole seems to be resulting in perhaps higher rates of skin cancer, and it's thought to be the N-oxide metabolite of voriconazole that causes this, although they're not totally sure. The other thing is, when this drug came out, we thought it was 100% bioavailable. It's not. It's about 80, 75% bioavailable. So you've got to watch your therapeutic drug monitoring a little bit as you bounce back and forth between IV and oral. The other thing, too, is all of the azoles we're going to talk about, Vori, Isa, Posa, they all really should be known as pharmacist job security, okay? Because these things shut down P450 systems like there is no tomorrow. And so the drug interaction list on these things is off the hook. Vori's drug interaction list is about as long as my arm, okay? And so really for our providers, they're like, oh, sweet Mary, call pharmacy. I don't want to deal with this. Okay? So this is pharmacy job security, but it's also really a place where we have to step up because the drug interactions here can really harm patients. You're not talking about a little bit of P450 inhibition. You're talking about big league, 3A4, 2C9, 2C19 inhibition. This is real deal P450 inhibition right here. The other thing, too, is we've discovered that voriconazole is not a benign drug. Voriconazole structurally is very close to fluconazole. And if I walked up to you and I gave you 6 grams of fluconazole, you'd be like, I wouldn't be able to grow a Candida near you for the next year, okay? But you'd be, no big deal. If I walked up to you and gave you 6 grams of voriconazole, you'd scream, you'd see Chewbacca on the ceiling, and then your liver would fall out. Okay? So you're talking about a drug that is much more toxic than fluconazole. And this hallucinations thing is flat out crazy. Okay? And what is very interesting about this is that patients, they'll be like, you're like, how you doing? Good. Noticing anything weird? I'm hearing a telephone ringing. Oh, wait, that's not a hallucination, sorry. But if you talk to patients, what they'll tell you is, you know, I am noticing that, you know, we had a guy in Texas who was like, the art at the foot of the bed, he's like, it is so cool. It is so vibrant. He's like, and it changes every morning. And we're like, there's no art at the foot of the bed. And he's like, you're not going to charge me for that new picture every morning, are you? We're like, whoa, whoa, whoa. So we checked his voriconazole level, and his voriconazole level was 10. It should be under 5. We dropped his voriconazole dose. The art went away. There was a great poster. What is May 4th? Anybody know? Star Wars Day, right? May the 4th be with you, okay? So, May the 4th, Star Wars Day, brings me to one of my favorite ID posters at a meeting ever. It is the NIH's experience with voriconazole and hallucinations. In the middle of the poster is a picture of Chewbacca. And it goes on to tell the story of a patient at the NIH who told his medicine team, I know Chewbacca's not on the ceiling, but Chewbacca's on the ceiling. And again, it was a situation where his voriconazole level was high. They dropped the voriconazole dose. Chewbacca was no longer on the ceiling. So, you know, you need to be aware that this stuff can result in some hallucinations, and it doesn't necessarily result in full-out altered mental status. And so you almost have to kind of ask patients if they're seeing or noticing anything weird. Posaconazole, I will tell you right now, Posaconazole in 2017 is the Posaconazole we wished we'd had for the last decade. Okay? Posaconazole initially was launched as this god-awful liquid formulation that you had to chant, dance, stand patients on their head, make sure there was no PPI in the building. You had to do everything right in order to get this stuff to be absorbed. It was a giant pain in the backside. There's now an extended release capsule formulation as well as an IV formulation that actually allow us to get Posaconazole into patients. Okay? So it's a really, really good compound. One of the things we've said about Posaconazole for a long time is how well tolerated it is. Yeah, it's well tolerated because nobody absorbs it. Okay? Drugs tend to be great if there's none of it in you. Okay? And so I think we're going to find out how well Posaconazole really is tolerated with these new tablets and IV formulation. The other thing, for everybody in this room, okay, You need to realize that the dosing of the liquid is completely different than the dosing for the tablets and the IV. There are now multiple cases in the literature of pharmacists and docs mixing this up, and it results in posaconazole toxicity. A little 11-year-old girl at a children's hospital came in with posaconazole levels off the chart and acting all kinds of not good because she was being dosed with the capsules using the liquid dose. Okay? This is something you have to pay attention to. Also know that the FDA now says that the tablets are the preferred formulation. The FDA says it. If the FDA says it, that tells you how lousy the liquid formulation is, doesn't it? Right? The FDA is what the FDA wants to say is, please take the liquid out back and shoot it. Okay? Because it's garbage. Use the tablets whenever possible, but remember that the tablets are dosed very, very differently. The other problem here is that the tablets in the IV are highly wallet toxic. Okay? Be very, very careful when you send patients out with tablets of posaconazole. Pharmacy acquisition on this stuff is about $60 a tablet. So imagine what the patient is going to get charged. Okay? This is big cash money we're talking about here. The weaknesses of posaconazole, I think you've already kind of hopefully figured out. I don't like the liquid at all. The tablets are awesome. The IV's awesome. The price isn't awesome. We don't know if the absorption is saturable with the tablets yet, like it is with the liquid. And the drug interactions, you're talking about major P450 inhibition. Okay, very potent cytochrome P450 3A4 inhibition, and the pH issues. You know, basically with the liquid, you couldn't have a proton pump inhibitor in the building if you wanted a patient to absorb this stuff. It doesn't appear that acid suppression impacts the absorption of the tablets. So I think that is a major advantage over the liquid formulations. Now, Isavuconazole, well, I want you to look at that name for a minute. Isavuconazole. Are you freaking kidding me? Why do you even need a brand name if that's your generic? I mean, that's crazy. And you guys, the toenail fungus stuff, Jublia, does anybody know the generic on that one? It's Efficonazole. It's another Echinocandin. Somebody at the FDA is having way more fun than I am with antifungal names, okay? So those are our two most recent antifungal names, and they're both a little bit funny. So the thing to know about ISA is that the spectrum is probably closer to posaconazole, okay? It does pick up the mucorales, and so I think that's a real strength of this compound. It's once daily, but what you're going to notice is that the stuff on the shelf says isavuconazonium sulfate, okay? It comes as a prodrug, and that isavuconazonium sulfate is converted once it's administered to isavuconazole. Okay, and so that's really important to remember because the dosing gets a little wonky and you have to watch that. You've got both IV and oral with no cyclodextrin in the IV. And really the major advantage to isavuconazole, it went head-to-head with Voriconazole for invasive aspergillosis and was found to be a little bit better tolerated. Okay, it appears that it may have fewer hallucinations, fewer liver side effects, and so I think that's really kind of the advantage here. It's only got treatment indications at this point. It's FDA approved for the treatment of invasive aspergillosis and the treatment of mucormycosis. It does not have prophylaxis data at this point like POSA does, but a lot of centers are using it that way. And then also remember, as we mentioned earlier in the talk, that all Candida species, if a glabrata is resistant to fluconazole, it's going to be resistant to all of the azoles, even your brand spanking new ISA. And this is, again, the data that I kind of touched on briefly that shows that ISA was a little bit better than Voriconazole with regards to drug-related adverse events, but that really everything else in the Aspergillus study was exactly the same. So, to wrap this up, you've got a 53-year-old guy with AML with normal cytogenetics admitted for induction therapy. He undergoes induction therapy. Neutrophils recover on day 26, and then he's discharged on day 29. He gets readmitted to undergo his allo hemostem cell transplant, easy to say, which was successful, and then he gets discharged home. But he comes back, unfortunately, and has a new nodule on his chest CT. Now, the question is, the guidelines say Vori, right? But this is going to be the thing that causes fights at ID meetings for the next decade. And the question is, should it be monotherapy or should it be combination therapy? This is a study of Vori plus Anidulafungin versus Vori alone for invasive aspergillosis. This is the Kaplan-Meier curve, survival, okay? So you want to survive, right? Anybody want to be dead? Hopefully not, okay? So you want to be on the top line. That is, and here it's Vori plus Anidulafungin. The bottom line is Vori alone. The problem here is that the p-value on this was 0.08. It was interpreted as a negative study. So the guidelines say you did not make your primary endpoint, therefore the guidelines are not recommending combination therapy because the p-value was 0.08. Which one do you want? Okay? And so I think this is going to generate major fights at ID meetings for the next decade. So when you look at toxicity and monitoring, remember that Vori is not benign. And I really think that basically everybody on Voriconazole therapy should get therapeutic drug monitoring. With Posaconazole tablets, the absorption is so much more predictable and reliable. I'm not sure we need therapeutic drug monitoring, but I think that the data is still kind of coming in on that because about 10% of patients may not make the levels we think they should. And the issue with Isavuconazole is that we really need further data. ISA is so new that I'm afraid we don't know what we don't know with regards to therapeutic drug monitoring at this point. And we've already talked a lot about this, but the drug interaction potential for this class of drugs is really something where pharmacists need to be seriously involved. So to wrap the Advanced Azoles up in 2017, you've got 3 at this point for invasive aspergillosis. The major difference is that Vori's generic. Vori doesn't cover mucor, but Vori's probably a little bit more toxic with the hallucinations and some of the skin cancer stuff becoming concerning. I really don't think the indications matter that much. I think that the 3 can really kind of be used interchangeably based off what you need them to do. And the spectrums, there definitely is difference in that Posa and ISA cover mucor, whereas Vori doesn't. But I think for Aspergillus, they're likely interchangeable, okay, as long as you're using the right formulations at the right doses. I've got a couple questions here that I think Randy's going to kill me if I don't get off the stage here pretty quick. Let's see here. Do you have, so question number 1 is about procalcitonin. Do you have any experience with using procalcitonin for antimicrobial de-escalation, even with antifungals? So procalcitonin, I think, for de-escalation of antibacterials is awesome. The data is getting better and better, and it's something we should be thinking about. It is much less clear in antifungals, okay? And so I don't know that it really has a role for starting or stopping antifungals at this point in time. So, should I stop with 1? I've got a couple other questions that came in, but we're a couple minutes over, so I'm going to jump off. If anybody wants to talk about these, I'm more than happy to meet you in the back, and we can kind of talk about these a little bit. So thank you very much again, guys. Have a great rest of your meeting.
Awesome.